Good evening, everyone. My name is Young Kim. I'm a neurosurgeon from St. Vincent Hospital, the Catholic Medical University in South Korea. I'm very pleased to have the opportunity to present here today. I would like to talk about precision targeting for tumor biopsy with utilization of brain perfusion maps for surgical guidance. These are main three themes for using cases of brain perfusion imaging in neurosurgery. First one is brain tumor surgery planning. The perfusion MRI is very helpful for assessment of tumor vascular density and metabolic activity. And also, we can guess the compartment within brain tumor preoperatively. And second, stroke and ischemic brain disease surgery. Assessment of blood flow disturbance and identifying regions of brain tissue damaging. Third one is cerebrovascular surgery. Diagnosis of blood vessel stenosis and cerebral hemorrhage is very important. Let's dive to brain tumor, especially high-grade glioma surgery. There are two main themes of this, precise surgical guide and biopsy site selection. I focused this one. There have been many studies about heterogeneity of high-grade glioma, so-called habitat analysis, as you know. This is about conventional perfusion-based spatial habitat analysis. Habitat used to analyze heterogeneity in complex lesions like high-grade tumors. Tumors are divided into functional or structural habitats, such as hypoxic regions. It means areas resistant to therapy. And hyperperfusion, it means regions of highly malignant growth. And necrotic regions is just literally necrotic or inactive tissue. These are Cercare advanced perfusion map. Above all, I focused these two, CTH and OEF. I have studied question. Are there any difference in pathology findings with two? How are they different? And which of the two areas would best represent the pathology of this tumor? I planned a selective brain tumor biopsy. Fortunately, the appropriate case arose, so I can proceed about that. 67-year-old male patient, glioblastoma. The round large mass with heterogeneous enhancement in right temporal lobe, accompanied by periregional edema and brain shifting. The tumor was located superficially, so there's no brain shifting during dural opening and tumor resecting. This is for surgical planning using brain lab navigation based on conventional T1 enhanced imaging. First, I focused on CTH, so I tried to do biopsy exact this point. This is surgical video. Orientation is frontal, anterior, posterior, inferior, superior. This point. Oh, I'm sorry. As you can see, I tried this point tissue. Tissue is obtained very carefully by tumor forceps. I think that location is CTH point. Next, I tried to OEF location biopsy. This point. The same orientation. This point is more anterior and more deep portion. Also, the tissue was obtained carefully, same patient, by tumor process. This slide is a key point on my presentation. Pathologic findings on CTH and OEF. First, this one is CTH. It has extensive necrosis and microvascular proliferation and high cellular density and pleomorphism. This is OEF finding. There have a vascular-centric necrosis and thickened vessel walls and localized necrosis. Main difference of these two regions is extensive necrosis and higher cellular density and pleomorphism. CTH is more extensive necrosis than OEF and higher cellular density and pleomorphism than OEF. So I think CTH is winner for aspect accurate diagnosis and predicting the tumor's progression. Based on this result, I planned further research plan. This is my study title. Development of precision guide protocol based on advanced brain perfusion mapping for accurate brain tumor biopsy. This is me for proceeding stereotactic biopsy. I use surgical assistant robot for during stereotactic biopsy. The name is Chimera. This is developed by a South Korean company, Goyoung Technology. It consists of navigation software and optical tracking sensor and markers and robotic guidance system. This is a robotic arm, and this video is how this robot works for stereotactic biopsy. Objectives of this study is as follows. Primary objective is develop guidelines using advanced perfusion mapping to improve the accuracy of stereotactic brain tumor biopsies. Secondary objective is evaluate the clinical efficiency of these guidelines, compare outcomes with traditional method, and explore personalized treatment strategies. The methodology of this study design is a prospective observational trial. Medical device uses like this, use advanced perfusion mapping to analyze tumor heterogeneity a guide biopsy site selection to target regions with the highest malignancy potential or most representative areas. I will analyze the comparison group. Conventional biopsy method will be used as the control to evaluate the precision guide protocol's efficiency. So, and I have to resolve that bias prevention, standardized protocols for data collection and analysis, and blinded evaluation of biopsy pathology results to avoid interpretation bias. Evaluation and analysis. So primary evaluation metrics is diagnostic accuracy of biopsy using advanced perfusion mapping, improvement in detecting high-grade tumor regions. Secondary evaluation metrics is clinical efficiency compared to conventional biopsy methods, impact on treatment decision-making and patient outcomes. Observation items are these: CTH, OEF, and CMRO2. So, and pathology result of correlation between imaging metrics and biopsy findings. I also analyzed to the statistical analyst plan. This study will have some limitations. First, intratumoral heterogeneity. Advanced perfusion mapping enhances the target selection, but may not fully address the complexity of high heterogeneous tumors. Second is sampling and operator variability. Risk of sampling errors and inter-observer variability in interpreting perfusion maps can affect consistency and diagnostic accuracy. Third one is device dependency. The reliance on specialized imaging software and equipment may limit the protocol's adaptation in settings with limited resource. Lastly, integration challenges. Partial compatibility between Cercare Medical's perfusion mapping and Chimera strategic surgical assistant robot may lead to workflow inefficiencies. This could result in potential inaccuracies in biopsy site targeting. Although these limitations, I will resolve it. And I believe that Cercare perfusion mapping will be very helpful to making brain tumor biopsy standard guideline. Thank you for your attention.
Thank you, Dr. Kim, for showing us your experience in the neurosurgical workflow with Cercare. And if there's any questions from the audience, please let us know.
Thank you very much for the presentation. Did you compare the novel perfusion maps with CBV? CBV has been standard to identify the viable tumor tissue for some time now. It will be interesting to compare the novel maps with the standard CBV map. I suppose that you have the material from the perfusion, so one could just look whether the new maps give more information in relation to CBV, which is established.
Yes, I will try. Yeah, I think your opinion is very important. So I have same opinion with you. Yes.
Thank you. Agreed, and I think also there's a publication by Anna Tietze from already 2015, which looked at the added value of CTH to CBV, right, which shows that it works across a whole range of gliomas, so different tumors. It was a collection of different tumors, and how it can add information and clinical value.